Alrighty. So good morning, everyone. Thanks so much again for being here at our quarterly meeting, our second one of the year. As usual, we are just going to get started with some introductions. I am Brooke Valerie. I manage the Long Island Health Collaborative, and I manage communications, health outreach, and research for the Nassau-Suffolk Hospital Council that oversees the collaborative. I'm going to kick it over to Janine.
Hi, good morning. Janine Logan, VP Communications and Population Health for Nassau-Suffolk Hospital Council and Director of the Long Island Health Collaborative.
Thank you. Hannah, do you want to go next?
Sure. Yep. I'm Hannah Moore. I'm the Director of Community Health Strategies with the Nassau-Suffolk Hospital Council, jumping into any of the Long Island Health Collaborative initiatives when I can.
And we have one new team member to introduce today, Olivia Bingham. Do you want to introduce yourself?
I'm the intern under Brooke this year, so I'm working with the Nassau-Suffolk Health Council, and I am the comm research and outreach intern.
We're really excited to have Olivia on our team. She is a great writer and has already been really great help to us. So thanks, Olivia. So I'm going to go down the line here of who I see. Christine Duffy.
Sorry.
No worries.
Okay, start. Good morning, I'm Chris. I'm from St. Mary's Healthcare System for Children. We service kids medically fragile all throughout the boroughs and Nassau and Suffolk.
Thank you. Adesula Watson.
Good morning, everyone. Adesula Watson. I'm the Director of the Office of Minority Health in the Suffolk County Health Department.
Thank you. Alicia Collinbell.
Everyone, good morning. I'm Alicia Collinbell. I am the Outreach and Partnership Specialist for Nassau Library System. So I work with all of the public libraries, all 54 of them in Nassau County. Nice to see you all.
Great to see you again. Thank you. Allison Puglia. I see you're unmuted, but if you are talking, we can't hear you, Allison. I'm sorry. Maybe we can come back to Allison here. Benjamin Correas.
Hi, good morning, everyone. I'm Benjamin Correas. I work for NYU Langone Health as a core program manager for Long Island and community engagement and outreach. I'm happy to be here and thanks for inviting me.
Thanks for joining us. Chris Hendricks.
Hey, good morning. I'm Chris Hendricks. I'm Catholic Health System Vice President for Community Outreach.
Thank you. Who's next here? Danielle Hislop.
Hey, I'm from Long Island Select Healthcare. We are a FQHC in Suffolk County that services IDD and underserved populations. I'm on for the CEO, Aaron Clark.
Thank you for joining. Who's next? Jack Schneerman.
Good morning. I'm Jack Schneerman, Vice President, Northwell Health. I oversee our collaborative efforts on the 1115 Medicaid waiver. I apologize for not being on camera this morning. I'm in transit.
No problem. Thanks so much for being here. Safe travels to you. Josephine Peterson.
Morning, everyone. My name is Josephine Peterson. I'm with NYU Langone Hospital, Long Island in Mineola and work for the Trauma Center as their injury prevention and outreach specialist.
Thank you. Kate Metzendorf.
Hi, good morning, everyone. My name's Kate. There's actually two Kate Metzendorfs on the call right now. My colleague Leah is also on the call, but we RSVP'd under one name. So there's not two of me, but we work for the Be Free team. We recently joined the team. So we're working to make Suffolk County and Nassau County different community spaces, work sites more lactation friendly. So we're grantees of the BFFNY grant. We're new to the team, and so we're excited to be here.
Thanks so much for being here. And to Leah as well for joining us. Kelly DeVito.
Good morning, Kelly DeVito from Horizons Counseling and Education Center. Nice to see you all.
Thank you, Kelly.
Maddie McBullion. can always come back to Maddie in a minute. Stuart Vincent. We can always come back to Stu too. And Susan McCabe.
Hi, Susan McCabe. I'm a nurse practitioner and PhD student with the College of Nursing at Medical University of South Carolina.
Thank you for joining us. Okay, so I know we didn't hear from Stu or Maddie. Please feel free to introduce yourselves, or if you'd like to do it in the chat later, that's fine. And is there anybody else?
Allison Puglia,
Yes.
she introduced herself in the chat, but maybe now, Allison, you have audio?
Yeah, I worked it out only,
Awesome.
12 years after COVID. I am the Payment Assistance Outreach Manager, and our team helps customers with bill assistance, whether it's discounts, problems with paying back arrears amounts, or medical issues. So please, anyone is welcome to reach out so that we can help.
Welcome.
Thank you for being here. So we'll just kind of show our agenda here. Our featured speaker today is Valerie Lewis from the Suffolk Cooperative Library System, although I don't think she has joined us yet, so we might jump ahead a little bit past her presentation to get to our updates first. But so this,
Yeah, you know what, Brooke? And I don't know if this is worth it, but there are a good number of new people on the call. And I don't know if it would be worth it for me to do like a quick recap of what the collaborative is, how it came to be.
that'd be great.
For those of you who've heard me say this so many times, I'll try and change it up a bit and make it interesting, but I just think it might be helpful because we have individuals from a variety of sectors and representing a variety of disciplines. And so, oh, hi, Tabor just sent it too. So just a really quick history. The Long Island Health Collaborative began about, 12 years ago, 2013, around there, 2011 or so, 12, 13.
Yeah.
And we really came together, all of the hospitals on Long Island and the 2 county health departments, because at the time the state was highly encouraging, and still does, that those 2 separate sectors work together on a joint community health needs assessment. We all always did community health needs assessment, but not so much in a collaborative and joint way as began back in 2013 when the Long Island Health Collaborative, or the Nassau Suffolk Hospital Council, which oversees the collaborative, became a natural coordinating entity for the 2, if you have the hospital, all the hospitals and the 2 county health departments, and many community-based organizations as well. So we came together, sat around a table, developed a survey to send out a community health assessment survey. We call it the CHAS. I give you all that Chaz rendition right now, but not really feeling up to it. So sorry about that. All that Chaz, whatever. And we deployed the survey, which we still deploy to this day, continually. It's changed a little bit as the prevention agenda priorities and focus has changed over the years. And we did that, and I thought, okay, so this is it. We did it, and we'll do it again in 3 years. But there was great synergy and energy, and the group wanted to continue to meet and realize that there was so much greater strength in numbers, right? This is greater strength in numbers and getting work done and making a difference through a collaborative effort, through a collective impact. So we continued to meet, decided to call ourselves the Long Island Health Collaborative. That was in 2014-ish, I think, at that point. Then there was some state money through the Population Health Improvement Program grant available in 11 regions throughout the state to do the type of population health management work that we were already doing. So we applied, and we received the grant for the Long Island region, which then enabled us to really step up our game in terms of more data analysis, being able to get access to Sparks data for research purposes, being able to do more qualitative analysis through community-based summits, key informant interviews, et cetera, to develop some programming such as Train the Trainer for cultural competency and health literacy, quite a number of initiatives that we were able to get involved with because we were able to expand staff and we had some money and we actually had some funding. So we went along, we did that. The Collaborative continued to grow and grow. We were able to obtain the attention of the state health commissioner, even the state parks commissioner, having them involved at some of our walks, because we embraced walking as a way to, one of the ways to manage or reduce or avoid chronic diseases totally, along with nutrition. So those were our two foundations. So we really were gaining momentum, and then COVID came. And everyone's momentum stopped, funding stopped, even though we had another year to go, or we did secure another year, never materialized. And so what we were able to do, of course, we switched to virtual like everyone else. I reached out to Collaborative members. They still felt that there was a need for us to meet at least virtually. So that's when we switched to a complete virtual platform on a quarterly basis. We still continue to deploy that community health assessment survey and now analyzing it annually rather than biannually. And our data gen is our partner that does that. And that data is available to everyone and is on our site along with some other reports and data analyses that we've conducted over the years. And so kind of that brings us, I think, to today, where, and we're going to talk about this a little later on, we're at the precipice of launching what we call kind of a case study about the Collaborative and its longevity and sustainability and how all the partners were able to achieve that and why was that achieved. And I think it's we're at a great crossroads right now. Something like this, I think, can provide evidence to the power of collective impact, evidence to the importance of public health and the intersection with medical health, right? The two working together. And as we maneuver through very difficult times right now in the political spectrum in terms of funding. And so we'll talk a little bit more about that later. But that's, I think, the best quick wrap up I can give everyone who is been involved with the Collaborative from the very beginning and those who are rather new, kind of a level set. So maybe help you understand where we're headed, why we continue to head in the direction that we head, and certainly what we could be doing that's different or more useful and helpful to each of you. So with that, is that still me? Am I still going here, Brooke?
No, that was a great history. Thank you for bringing
Okay.
us to the present day here. You're right, there were some new folks, so I'm sure that context was really
I hope that's helpful.
I am just going to stop sharing for one moment and jump
Okay.
ahead in our presentation. And we will cover our updates first before Valerie gets to her presentation.
Okay.
Just pull these back up here.
And it's interesting, Valerie is the Suffolk component to the Nassau person, and I forgot her name. What's her name again?
I'm here.
Alicia.
Alicia. And I worked with your predecessor, two predecessors ago, I think, at this point. And again, thank you for, because you are, again, a central body, right, connecting all of those libraries, and libraries have been so key to us reaching out to communities. They're I always say, a treasure, a hidden treasure in every community. So thank you for that.
Thank you very much. We appreciate that.
Finally gonna share my screen again. Sorry about that.
Okay, there you go.
Here we go.
Okay.
All right, so Janine, do you want to talk a little bit about the case study?
Yeah, I'll talk a little bit about this. Hannah Moore, who is really taking the lead on this particular project, and we just had our first subgroup meeting yesterday, and I think we are well on our way to understanding what it is we want to do. And it really is. I think the preface that I gave about the history sets us up for why we want to do this case study. And there's lots of enthusiasm from among the subgroup. At least I sensed that yesterday. And the ultimate goal, what we're going to focus on is the processes that we've used to get to where we are, how we were able to build a coalition really from nothing, how we were able to take two counties that, quite frankly, had two different political leanings, and still do, to come together. No, they still don't. No, do they? I can't remember. I don't think we do. I think they're both Republican at this point. So come together. And then all of the hospitals, who in effect really are competitors when you think about it, to take all of those individuals and those institutions that, of course, are working first and foremost for their own objectives and their own plans and goals and whatnot, to have them all come together and realize how we can be so much more effective when we work as one rather than work as individual entities. In many cases, some cases we still have to work individually, obviously. That was the genesis for wanting to do this. And of course, the ultimate goal is getting this article published in a journal of some sort so that we can inform the field, let others know how we've done this. And we've done this, we did have funding for 5 years, but mind you, 5 out of the 13 that was funding, the rest of it was unfunded. So we really kind of do this on a shoestring budget. Actually, no budget really. It's just kind of subsumed into my work and Hannah's work and Brooke's work. And how collective ownership, we want to demonstrate that and the power of it and what we've been able to do, and how you sustain that over time, whether or not you have any funding. Funding's always great, but that's not what we have, but we still forge ahead. So I don't know, Hannah, if you want to add anything to that. You probably took better notes than I did yesterday.
I think you hit everything. You took the words right out of my mouth.
Did I?
Yeah.
Really? How? That's amazing. Well, I'm glad to hear that. Well, maybe since we have a couple of the individuals on that subgroup on the call, maybe they might want to fill in some details that I might have missed. Tavora maybe, or Chris maybe.
I think you really hit on it, Janine. That hopefully this is going to highlight the process that has changed, evolved, been flexible, tailored along the over 10 years that the Health Collaborative's been together, and highlight the lessons learned, as you mentioned, and ways of replicating it.
Yes.
So that's really the goal. So I think it also will serve as a nice historical piece for us.
Yes, and everyone will take collective ownership of this. And our goal is the subgroup's going to meet each month through the end of this year. Next step is putting a really great discussion yesterday, put a framework together. I don't think we're meeting the end of July, but probably not August, whatever. But by the end of the year, really, I would think probably have a pretty good draft done and written that we'll all look at, we'll all discuss, and then we'll move to have it, we'll contact journals, and we've already been investigating journals, what their requirements are, and so we'll tailor it to whatever journal that we might target. That would be step 2. Is that right, Hannah? Did I get that right?
Yeah, absolutely. So I guess the only thing to add then is if you're interested in being a part of this, if you feel like, something I brought up yesterday was that us at the Collaborative who organized this, we can write all we want about what it's meant to us on the inside, kind of, but really the moving piece comes from you all as participants. So if you are interested in adding to it, please feel free to reach out to any of us, to me or to the like email. And our next meeting will be, like you said, Janine, July 30th, I believe
I
it
think,
is,
yeah.
at noon.
Right. Chris, want to add anything?
No, I think you covered it all,
Yeah, but you came up with a great working title.
which I can't even remember. I just remember it had waves and innovation and collaboration.
Yeah, yes.
And
was
the word ignite.
That's right.
ignite.
That's right. Yeah.
Right. I can almost see the visual already on the cover with the word ignite. Anyway, that's getting way ahead of ourselves. Okay, so yeah, so Chris and Tavora are, well, I don't want to date any of us, but we're of the old guard and have been doing this from the beginning of time, and really appreciate the input from both of them, because they do understand this work so very well, and appreciate all that they have done and continue to do. So I guess that's the update for the case study. And of course, if anyone wants to discuss that right now, please do. I mean, there's other individuals on the call. This might be the first time you're hearing about this, although we have been discussing it, I think at the December meeting, and maybe March too, probably March as well. What your thoughts might be, anyone who was on the call yesterday, on the subgroup call yesterday, if you also want to chime in. I know Susan, you were on the call. I'm trying to see who else was on there. Not to put anybody on the spot. I don't want to put anybody on the spot. Selena was. And anyway, anybody who wants to add to that, you're welcome to. But I do see that Valerie has joined us now. So do you think we should switch over, Brooke, to Valerie's presentation?
Absolutely.
Okay.
So let me just toggle here. Good morning, Valerie.
She's muted still. There she goes. Hi, Valerie. Oop, where'd she go?
Oh,
did she leave?
No, she's still here. Can you hear us, Valerie? I saw her mute and unmute, but we still can't hear you, unfortunately.
I don't have her on my list anymore.
I think she might have just exited.
She might have exited in error. But anyway,
there she is.
Oh, there she is. She's back with us. Hi, Valerie. There she is.
Can you guys hear me?
We hear you and we see you.
Great. Sorry about that.
That's okay. Perfect timing. And as I said, Valerie's going to give us a little bit of a presentation. She is a staunch advocate for those with disabilities. She is currently Administrative Outreach Services, Outreach, and the American with Disabilities Act Liaison for the Suffolk Cooperative Library System. And she's been a partner with Stony Brook Medicine's program in public health, particularly the Healthy Libraries program. And she's been a partner with the Collaborative from way back in the beginning as well. We worked together on a research study. Remember that, Valerie?
Of course.
Going to randomly selecting libraries in Suffolk and then doing the same thing in Nassau to find out just how equipped or how often library employees are the patrons approach them about different social support needs and health needs. Where do I sign up for SNAP? Where can I get assistance with my utility bill? That would be you, Allison, right? From PSE&G and all of that. And it has led to the placing of social work interns from Stony Brook University in a number of libraries, at least in Suffolk, and may also be in Nassau as well. But anyway, without further ado, let me turn it over to Valerie, who's going to talk to us about ensuring access to health care services, particularly for those who are experiencing disparities and disabilities.
So thank you very much, Janine. I will give out apologies ahead of time, just in case I do get cut off or cut out. I am upstate. Internet access is not good. And so apologies ahead of time for the timing. You know, big sagas always come. A close friend passed up here, so we needed to be up here. That very, very mature in age, but still sad.
Nonetheless.
Still sad. All right. So I will say thank you, everyone. I appreciate your time. I'll just take a little bit of your time to do a very brief portion of a presentation that I might typically do for any type of organization. This one particularly focusing on healthcare. As Janine said, I am the administrator of outreach services at the Suffolk Cooperative Library System. So while my work focuses on public libraries and outreach services, I work with many of you on many different programs, projects, services for not only library patrons, but also library staff and administration, so that they are aware of what is out there and what they can bring to their patrons. So it's a really important effort to really bring together everyone as part of the larger picture. And I will, say to all of you that are not working with me on some kind of project to bring to the community, I am happy to work with you in that effort. A lot of my other focus, all of my focus in everything that I do regards people with disabilities. You may or may not be aware that we unintentionally create barriers to people with disabilities in almost every aspect of what we create, in almost every program we create, and in almost every service that we offer. So it's important that we understand not only the law, the ADA, and other legislation that might apply to providing access to people with disabilities, but it's also important to understand some basics of just common sense approach to why are we doing this? Who might we be unintentionally excluding from our programs and services? And how can we do things differently? So again, this is really just a small portion of a larger presentation that I'm always happy to talk about with any of you. So next slide, please. So let me just start off by saying that accessibility should not be viewed as a job-specific title, task, or skill. It is everyone's responsibility. So the entire organization should be part of any types of decisions that you make, developments that you talk about, plans that you're planning for your services or your organization. We like to use the word inclusion a lot, particularly in the past few years of our life. But it's important to note that different studies have shown that 96% of different trainings related to diversity and inclusion do not include any information about people with disabilities. So it's always important to pay attention to what type of trainings you attend and what is missing from those trainings. Next slide, please. Some of the types of things that are you want to think about in healthcare in particular, you want to think about, are these items or services accessible in the environment in which you provide your services? And there are a lot more things to think about than this, but these are, again, in this short presentation, some generalities to keep in mind, okay? So when you're marketing, when you think about your websites and your social media, are you fully aware of how to make these things fully accessible to people with different types of disabilities, people who use different types of assistive technology to access your website, to access your social media? Do you create social media that is easy to understand? Do everyone here is fully aware that literacy rates are very low? So when we, as maybe more wordsmiths with our information, put information out there, a lot of people that we're trying to reach don't even know what we're saying to them. And I see that a lot from things that come from different healthcare organizations. But it's really important to think about what are the marketing materials that you put out there in the world and what formats are they in. When you talk about patron, librarian in me, when you talk about patient services and you think about your waiting area, your signage, different things, right? A lot of times I'll go into a waiting area in a healthcare facility and it's chair on top of chair on top of chair with a table wedged in front of it. And there's nowhere for a person who uses a wheelchair to fit a wheelchair into that room. So they're kind of stuck in the middle of the room or off to the side somewhere. Person who uses a walker is always fighting with a table or the chair on top of chair on top of chair. We really don't have any good signage in a lot of these locations. Signage is often up high on a wall. So if you are looking at different signage, many people are living with vision loss, particularly as we have an aging society. I recently read from the National Council on Aging that 11,000 people a day turn 65 years old in this country. If that's an accurate status, then there's a lot of changes we need to make to the facilities that we are offering to the people that we serve. Signage should also be at eye height and good contrast so that people can figure out where they're going. Often it's, again, way up too high. There's often no tactile signage for people who might need tactile assistance in order to get places. And we just don't create things in accessible ways in different areas. In terms of healthcare resources and information, all of you have seen things like brochures that talk about preventative things for cancer and be safe with this and be safe doing that and this. Have you ever seen any of those materials in large print? I've not. So again, I think many times we're excluding an entire population of people over a certain age, people living with vision loss. And this includes, people who speak other languages as well. There's no materials that are developed in accessible formats that talk about preventative issues. So how are individuals with different types of access needs supposed to access this type of information when we make little brochures with little tiny print that are on glossy paper that are not designed for much of our population. And so they then become at greater risk to these types of illnesses, chronic conditions, and diseases. We also want to think about what kind of paperwork do any of your organizations, when you're filling out if it's a hospital, if it's a doctor's office, admission papers that are in different formats, large print, tactile types of information, easy to read information, discharge information, follow-up information. We all just expect people and kind of force people to sign things that they don't even know what they're signing. And that's not to imply that the sighted person might sit there and read every word of what they're signing. But the point is, we should have the right to be able to see what we are signing and understand what we're being given. The return rate to hospitals for seniors is always off the charts. And I'm certain that part of the reason, and I'm sure you researcher people out there can take this and go with it. But if you send people home, people who are 65, 75, 85 years old, and you send them home with information in an 8-point font, in words that they don't understand, it's an unlikely scenario that they can really follow the information that you're giving them that is meant to be preventative from them coming back and needing additional services. Different types of communication services in office or on phones. Many of us, for cost cutting purposes, we use things like different automated phone services, which are quite honestly very confusing. I'm almost 65, but I still find most of the phone automation things quite confusing. They don't take me to where I want to be. And that kind of forces a lot of people just to give up on trying to get information, or it frustrates them. And that's certainly an unnecessary situation that we need in office or in hospital types of communications. Do all of you have things like assistive listening systems? I know many places use things like language line, or they might use things like an interpreter for different things, but many people who are living with hearing loss do not use interpreters. They don't know American Sign Language. That's not the broader scope of people living with hearing loss. So things like assistive listening systems and paper and pencil or paper and marker, depending on who you're interacting with, these are simple tools that you can use. Resources that are for interactions. How many of you come across a talking kiosk, right? So they're completely inaccessible. They don't follow any of the ADA guidelines or different types of legislation that are out there to make things accessible. People have to check in at kiosks in all of these different healthcare environments. If you are visually impaired, you cannot use them. And you stand there. And so then if you can find a person who can help you, you are 5, 6, 7 people behind the other people who were able to check in at the kiosk. And so that certainly is not equal access to healthcare. Things, again, the way you set up a room with exam tables, things like this, where are they placed in a room? What are the obstacles to get to those things in a room? Different stools, different chairs, different things that are in the room that people have to navigate in order to get to exam tables. And of course, hoping that all places have some type of accessible exam table, because a person using a wheelchair or a walker often cannot jump up on a traditional exam table. So they're certainly not having the same kind of access to healthcare. If you're in a healthcare setting in a hospital or something like that, in terms of menus and things like that, are all of them available in accessible formats? Computers, I like to bring those up because everywhere that you go to a healthcare environment, there are computers, right? So a doctor is talking to you, but they're typing on a computer at the same time, or a healthcare technician is talking to you and typing on a computer. So if you need to see their face, you don't. It's at a computer. So you can't see their face. If you rely on gestures, if you rely on lip reading, you can't see their face. You might not be able to hear them because they're facing in a different direction. The same thing is where You might be standing in the room. I've been in examining rooms where the computer is behind the examining table. So the person is standing behind you and asking you questions. And certainly, again, can't see them. Masks, they may be a necessary part of healthcare, but always keep in mind that someone may not be able to see you, be able to get your expressions, be able to read your lips. They probably can't hear you properly, and they probably can't understand you properly. So it's just important to keep these things in mind. When people leave doctor's offices, they'll often leave with an appointment card that's about 2 inches big. Do you offer things that are larger? Do you offer readily available? Do you say things to people like, oh, do you need this on a larger sheet of people, without putting that burden on the individual and always making that individual be uncomfortable? Do you offer these types of things? Do you keep markers at the desk so you can write things in darker print for people and make things easier so that you're not just giving something to someone that's absolutely useless to them? Counters in many environments. A person walks up to a counter, the staff member is sitting way down on the other side. So if someone comes using a wheelchair and is standing in front of the counter, they can't even see the person on the other side. So that's complete inaccess to healthcare. Sometimes there's a cutout for someone who uses a wheelchair. Most times there's not, particularly if it's not a brand new doctor's office, and many times they don't set those up properly either. And then finally, what type of knowledge does the staff have about making sure that things are accessible in that environment? Next slide, please. So some just accessibility basics to keep in mind. Access compliance is required, not optional. It's not your choice to make things accessible or not. It's your legal and, quite honestly, moral and ethical responsibility to make sure that everything is accessible. You want to make sure, just like you put a budget together every year for stuff, that accessibility is part of the budget that you discuss every year. Everyone should have ongoing disability awareness training for all parts of the administration, employees, anyone who deals with your organization, your security staff, volunteers, different associates, vendors, anyone who's part of the structure of your organization should be attending disability awareness trainings so they understand the different complexities of what you need to provide. You should have procurement policies that and procedures that have in it that you purchase things that are accessible, that you only work with website designers that understand full ADA compliance issues and don't try to make your web page accessible by adding on widgets or software gadgets, like the different products that are out there. And you need to understand all of that. That's your responsibility. How are you providing services from pre-COVID to post-COVID, right? We used to handle things differently, and now we may have created unintentional barriers in some of our healthcare settings that we need as safety features, but create an extra level of inaccessibility for people. There are more people with disabilities. Again, if 11,000 people a day are turning 65 years old in our country, if you live in Suffolk County, the only thing you see being built in Suffolk County are assisted living facilities and senior living communities. And I think that should give you a clear picture of the kind of services and the kinds of resources that we should be providing. What do you know about accessibility? Do you have any personal experiences that you can share? Not saying that all of them are the same, but what types of intricacies can you pull from that to be able to share with others? Understanding transportation barriers, things like paratransit. If any of you know anything about people who are trying to access healthcare, they're using a SCAT bus or Able Ride. If you've never ridden a SCAT bus or Able Ride, lucky you. But you could, people could have an appointment. They could make a bus that should get them there well in times of their appointment. They could live 20 minutes from where their appointment is and be on a SCAT bus for an hour and a half to 2 hours by law. So, you know, the law allows them to do that. So many people miss their healthcare appointments, and offices may not be able to be flexible. Sometimes they will not be flexible, but sometimes they cannot be flexible in being able to fit you in. So people miss many appointments because of the kind of transportation obstacles that they face, particularly in Suffolk County. You will get started with understanding a lot of these things by accessing federal, state, and local resources that I will leave you with after today's presentation. Next slide, please. And then here are some of them, not gonna go through them all, but all of them are different resources that you can access primarily at no charge, different webinars, different types of trainings, live trainings, mostly online, that you can use to better understand how to make things accessible and how different types of disabilities need different types of accessibility. I'm particularly fond of Georgia Tech Center for Inclusive Design and Innovation. You find useful resources there. And of course, you want to visit the United States Access Board. They do a lot with diagnostic equipment, diagnostic medical equipment, and how those things need to be accessible. Next slide, please. Here is a list of different technical assistance centers across the country. Technical assistance centers are there to provide trainings, sometimes at a fee, sometimes free. Many times they'll do virtual trainings for free, but they will do on-site trainings in terms of accessibility for a fee. Our technical assistance center is the Northeast ADA. I've worked with them before. They're very accommodating, but I would, there are 10 technical assistance centers. These are the 5 that I use most for no other reason than I find them most useful to the purposes I need to serve. Next slide, please. And then another just kind of thought to leave you with is effective communication. It really depends on the individual. You want to figure out what is the best way for me to communicate with the individual. It could be someone who may have a disability. It could be someone who may have low literacy skills. And because one kind of method or strategy has worked in the past with someone else, please don't clump everyone together and think that, oh, this worked in the past, it'll work for me now. Interact with that individual and find out what will work with them best so that you can really communicate with them effectively, find out what they need, and find out what you need from them, because you're going to need to get a lot of information from them. So do communicate with people as individually as you can to try to figure out what is the best method. Next slide, please. And then finally, I just want to let people know, a couple, maybe about a couple of years back, I started just a little very informal kind of discussion group in regard to people with disabilities and healthcare disparities. I hear a lot about healthcare disparities for all the different groups that we have in our society. And I never really hear anything about addressing the access needs of people with disabilities. And I'll remind everyone that it doesn't matter what color or gender or religion or race or, you know, anything that you are, disability can impact anyone's life at any age. And it doesn't just impact that individual, it impacts their family, and it impacts society as you know, an economic issue. And so it impacts society as a workflow issue. And so there are many aspects of disability that really are not taken into account when we are looking at how we're providing healthcare. And again, this very informal discussion, people are welcome to come and, you know, for an hour on a quarterly basis, bring something interesting to the conversation. If you want to become part of that conversation, just send me an email at valerie@suffolknet.org. And then, you know, what I'll say is that it's an ongoing discussion that is not going to change. We're not getting younger, we're not getting healthier, and we're just not doing things as a society that make people healthier. And so we're going to really have to figure out ways to be more, if you want to use the trendy word, inclusive of people. Then we really need to look at how we are, again, unintentionally not including people with disabilities in the wonderful resources, projects, programs, and services that we are creating. So that's my spiel. I really appreciate everyone's time, and I'm always here for discussion, and look forward, as always, to working with all of you. You do amazing things, and I appreciate your time.
Thank you so much, Valerie. And, you know, we'll open it up for questions in just a moment, but just wanted to make a couple of observations. Some of the issues that you pull up, like transportation, the problem of transportation, which is intractable here on Long Island, was one of the issues that's repeatedly uncovered when we deploy the community health assessment survey. As far as staff training and making sure facilities, at least I can speak from the hospital end, are ADA compliant. They are, yes, under regulation that they have to be ADA compliant, both from CMS and from the Joint Commission. Otherwise, there's, I believe, some penalties that they get slapped with. I do know that, and some of my hospital colleagues can chime in if they want, spend an inordinate amount of time ensuring that their materials are health literate, because yes, we do. And again, that's also what comes up again and again in that community health assessment survey, are individuals who are frustrated because they're getting information that they can't understand, or the technology, right? You call up and you get the endless hit this button, hit that button, hit this button, and it is discouraging. And so that has been voiced over and over again by many of the individuals we've reached out to. How that problem is solved, I'm not quite sure. And then there's lots of staff training, I think, that all providers present and offer to their staff members. So just wanted to make a couple of those observations. And I think that from the collaborative's perspective, would love to perhaps meet with this group that you have and do almost I guess a kind of a focus group, and maybe get their input, do a qualitative analysis of what they have to say, see what the recurring themes are, which we probably know what they are already as they've been for so many years. We kind of chip away at it. A lot of it has to do with funding, and funding right now is not a pretty word, right? It's kind of disappearing from so many different segments and sectors of the healthcare system. So just wanted to say those couple words. Great information. Love how you put everything in one spot, all of those resources that you have at your fingertips. And just wanted to open it up for questions if anyone had any questions.
And before, if anybody did have questions, I'm very excited to answer them. But I also did want to say, you know, the two things that I do want people to keep in mind is there is ADA compliance, but then there's, and yes, there are penalties if different hospitals and things like that are not ADA compliant. But there are also things that ADA may not specifically spell out that fit under ADA compliance, but we don't see in places. Again, I'll use as an example, we don't see, we put a lot of money and time and effort into resources for preventative care, things like brochures, things like, and those things are never, you don't see them hanging on a wall. You don't see them out anywhere in accessible formats. You don't see them brought to even senior environments in accessible formats. I've been to senior centers and senior events and senior fairs where the same tiny print type things are disseminated amongst everyone. So, so that's an issue to think of. And then the other thing I'll say is, yes, while funding is an issue, I think knowledge is a much more important issue. And I think that the resources that I've shared, particularly the ADA technical assistance centers, I would encourage everyone to, if you're not already subscribed to their e-newsletters, to do that, because you will see free virtual trainings offered all of the time that have to do with general disability type concepts, that even if it says for a specific group or a specific thing, I would register for it, because it gives you insight into something that's going to help you to provide a better service. And all of those are free. So it's, while funding remains a huge issue for certain aspects of things, I don't think it's the overwhelming, compelling barrier to this.
Right. Anybody have any questions?
There is a question in the chat. Christine Duffy, she thanks you for this outstanding fact-filled and thoughtful presentation. Are there companies that will review a company's website and marketing materials and make suggestions for how to make them more ADA friendly?
Yes, there are. So there are a couple out there that are pretty well known. One is called Level Access, and I believe Georgia Tech, which is on my list, will also do that. And then we have one right here on Long Island. We have something called the Viscardi Center, which probably many of you know, that do different types of things. Most of you probably know they started out as a resource for people who were blind, but have merged into many different things over the years. But the Viscardi Center does training, they create websites, they can evaluate your website. Yes, so there are companies that can do that. And also, you can most likely reach out to the Northeast ADA as well, and they can work with you on that as well.
Thank you.
Thanks, Valerie.
You're welcome.
Any other questions before we let Valerie go? Don't see any questions. I see no hands raised. Thank you again, Valerie. As I had said, she's a very impassioned advocate, as you can see. And I'll say, what is it? Is there one new?
Just a thanks from Alicia.
Oh, okay. And we appreciate your time and you and my sympathies to you for the situation, the reason
Thank you.
why you're up there.
Thank you.
Upstate.
I'm just so glad I didn't fall off. Fine.
You didn't fall off, you stayed on. So there was a strong signal throughout. So that's good.
Have a great day, everyone. You be well.
Thank you.
Take care.
Bye-bye.
Take care.
Okay.
So we do have one more speaker who is going to be our member spotlight today. Janine, do you want to introduce Lori?
Sure. Oh, there she is. Hi, Lori. Lori's Executive Vice President of HEALY, which is the Health Equity Alliance of Long Island, which is also serving as the social care network for Long Island, and working with that 1115 waiver. So I think this is a really timely topic to bring up right now. Lori is working very hard, she and her staff, in trying to get every Medicaid member screened to see if they, to screen initially and then to see if they screen for enhanced services. And she'll go into, there are 4 enhanced services that a Medicaid member from certain populations might be eligible for. And again, we talk about collective impact. And it takes an army really of, I think, community workers, community health workers, and other individuals to reach out to get to all of these Medicaid members. And Lori's kind of the general of that army, and has been able to pull in a variety of community-based organizations to assist in this work. And I believe there's some funding to assist you in doing this work. Some of you may already be doing it. So I wanted to give Lori the opportunity to talk about those efforts and see what recruits she might be able to obtain from her presentation, and any other ingenious ideas that any of us might come up with to make sure we reach out to all those Medicaid members. So I'll turn it over to Lori.
Thank you so much. Thank you both, Brooke and Janine, for having me here today. And it's nice to see everybody. As Janine said, actually Janine's a part of our governing body of Healy, was elected to it back in the fall. We are the social care network for Long Island. The Health Equity Alliance began in 2017 as part of the first 1115 waiver that we had, DSRIP. It was a CBO planning grant that began. And it was, there was a lot of dollars that came out from that one as well. And we got a small amount of monies to be able to build out a network of CBOs that would be able to think about how do we coordinate social care provision with healthcare provision. It was the very beginning of that. We focused those efforts a lot on infrastructure meaning technology. We began using Unite Us back then as a referral platform, and then also CHWs, community health workers, who we know we need a workforce in order to be able to do this work. And we've been convening since then monthly, our steering committee, which now has evolved into a governing body. Like I said, Janine's on with us, and we continue to have committees and meetings to be able to do this work, and a lot of responsibility to build out an even stronger network. So this is the way that the state has defined the social care networks, the Medicaid members in the center, which we agree with. The Medicaid members should be in the center of care. And then the social care networks, that like medium blue color, it includes the social care network lead entity, which is the Health and Welfare Council of Long Island, is the lead entity of the social care network, community-based organizations, healthcare providers, large and small. So it could be a small mom and pop primary care or pediatric practice to a very large health system, and FQHCs, everything in between. And then other HRSN service providers, meaning those specific HRSN services that were required to provide as part of the waiver, is also, these providers are as well. The outer blue, that navy blue, is the ecosystem, meaning really important stakeholders to the success of the social care network, and entities that we interact with all the time, knowing that we want their input and their participation to strengthen the overall ecosystem. So managed care organizations, health systems, local government, child and family supports, and other partners. These are the goals. We do need to screen all Medicaid members by March of 31st, 2027, of which point there's about 620,000 at this point. There was a higher number. It has decreased because of changes in eligibility. We're using the Accountable Health Communities, the HC screening tool, which is selected by the state, tweaked just a little bit to make it New York style. And so everybody will be screened for that. And then we will determine through an eligibility assessment whether people are eligible for these other additional services, refer and connect them to those services, and really make sure that they're also connected to traditional social care services. There is a fee schedule for this. So we have received a grant to do these dollars, as well as we receive as the lead entity, dollars a PMPM from each managed care organization. We're contracted with 15 managed care organizations. It was very much dictated by the state at this time. This wasn't a negotiated fee schedule. It's a state determined fee schedule as to the dollars that we receive, as well as the dollars that we pay out to CBOs and healthcare providers to provide the screening services, the navigation, the determination for eligibility, as well as those additional enhanced services. If you're eligible for those enhanced services, a Medicaid member, they would be connected to nutrition, housing, case management, and transportation to and from these services. So there's a fee schedule that's determined by that. These are the enhanced service eligibility population. So when someone's screened, we get that information. It's either can be done off platform, meaning off of Unite Us in an EHR. Otherwise, it goes to HealthX and comes back down into Unite Us, or it can be done directly into Unite Us, in which case immediately that eligibility assessment can be determined if they're one of these populations. And there's a couple of other clinical criteria that needs to be met, then yes, you would be eligible for these services, these nutrition services, housing services, and care management services. So it's kind of a process. It's screen. Do you screen positive for a need? A lot of people do. You go through the eligibility assessment. Are you eligible for services? And then yes, you are. It's that referral to these services. And all of the screens can occur off platform, but the navigation, the determination for eligibility, the referral, and the additional work related to those referrals all must occur on Unite Us for the platform we've chosen for Long Island. And payments occur as well too. So we'll immediately get invoices for our services that have been rendered, and we pay out on those. So where are we? So we've been, it's almost a year. We've been in contract with the state. It was August of last year. We've gone live with starting to roll out service delivery as of January 1st. We've screened over 3,200 Medicaid members to date and determined eligibility for those enhanced services for over 1,700, completed services for over 400. We've contracted with over 81 CBOs and healthcare providers. A large number of them are our CBOs, but we've also kind of added along the way a lot of primary care practices, our health systems, and our federally qualified health centers. So it's not just a CBO network, it's a network of CBOs and healthcare providers. The trick, though, to this is that we have 30 providing services. We need to get that 30 to be 81. We actually need that 81 to be over 100. We need the 30 to become 81. That's where we're really spending a lot of time ensuring that we're providing resources. We did receive a grant from the state to be able to provide resources to CBOs, not to healthcare providers, but to CBOs, to be able to ramp up staff, ramp up computers, ramp up cybersecurity, all the things that need to get ramped up to participate in this. And we've already reimbursed for about $140,000 of services. So we've been reimbursing very rapidly. We know people need to get paid. And so we've been doing that work. And this is where the reimbursements have gone. Heavy in screening and navigation. Screening and navigation is that onboarding to other services. So it's been heavy in that space that we've been reimbursing for. The eligibility assessment, nutrition, we've stood up a little faster. It has a little bit of an easier workflow. The housing, some of its housing remediation has a more complex workflow, and we are going to be rolling that out within the next couple of weeks. We have a bunch of committees that we put in place to be able to receive input. We have a governing body that gives us input, but we also want to make sure we're getting input from everybody else that we can. We have monthly healing meetings, but we also have a navigation care management committee that has launched and will be reconvening on August 6th. And that's really looking at this specific care model. We've heard a lot, there's a lot of case management out there. We're not the only people managing care for individuals, for Medicaid members. How do we look to see what specifically is this care management model that we're looking at, which is related to these services? And how do we distinguish it? And how do we make sure that CBOs feel comfortable if they're getting paid by Medicaid to do other case management, that they can also do this? And we've gotten a lot of clarification from the state. So we have a committee that kind of looks at that work. And again, looking at that navigation, and specifically, if you are a CBO that currently provides case management as part of a health home or BHCC or some other Medicaid paying way, we've looked at specifically how do we create a separate business opportunity for you, and specifically around this navigation and what does it look like, and how do you kind of pull together the resources to be able to hire folks and be able to provide these services. We also have a CBO engagement and capacity building committee. As I mentioned, we are able to provide capacity building resources to contracted CBOs. You contract, you're automatically eligible to have a very small light touch application. We tend to focus some of it on where our network gaps are. Care management is a network gap. We need that. Other services are a network gap. So we tend to focus that capacity building dollars on that. And we have a committee because we do ask for a monthly report out on how those resources are being utilized. And then once a month, we ask you to participate in getting these resources. We'd like to hear from you. What's working? What's not? How can we support you better? What's going on? How do you talk to each other and make sure you're supporting each other? So we do have a CBO capacity building and engagement committee. That's actually meeting next week. This is in terms of those resources. We have stipends, which are just engagement stipends. You made it through the contracting process with us. You've done the basic training. We do provide resources. I think it's $3,000 total to folks. In order to do that, we've paid out for 34 CBOs over $100,000. And the capacity building contracts overall, again, we focus them, like we've done them in waves, and we've kind of focused them based on where the gaps are. What do we need to start to stand up? How do we incentivize people to be the first people out of the gate? Because some CBOs are like, yes, we're going to be the first ones out of the gate. And others are like, yeah, I'll wait and see how this goes. Well, we're trying to incentivize, use these resources to say we need more folks to be the first ones out of the gate and trying it and trying out the workflows, giving us feedback on workflows. So we've had to tie these capacity building dollars to that. We've awarded nearly $6 million. Again, we're just doing our latest round. And we pay out half and then we pay out the second half. Again, we do require brief monthly reporting and participation in the committee. And then we also have these other charter stipends that we're doing. Like I said, we've looked for different ways in which to incentivize. We're doing additional resources for CBOs that are going to be those first out of the gate and providing those resources for that feedback on the workflows and the way in which the services are provided. Because we want to hear from folks. But you have to provide the services to give us the work, to give us the feedback. So we're incentivizing all of that as well. We have a data and technology committee. A lot of this committee has been focused on our healthcare providers who are looking to screen off platform in their EHRs. There's a lot of kind of, it takes about 3 weeks to tell you the truth. And I like to be honest with folks as healthcare providers, smaller healthcare providers or larger healthcure providers are coming on. From the time when you decide, okay, we're going to send a screen in our EHR, for that data to flow up to the data warehouse, the state's data warehouse, back down to our QE, our qualified entity, HealthX, back down to us. It is not a perfectly seamless process. It's not like a light switch that gets turned on. There's a little bumps in the road. And it takes some time in which to kind of work those kinks out. It takes about 3 weeks, to tell you the truth. And that's with my team staying on top of those screens and saying, where are those screens? We need to know where they've made it through the process. So we have a committee that talks about this, and it kind of shares lessons learned, shares what's going on in one EHR versus another EHR, and trying to bring things up and to the surface. Eventually, we like to move this committee once things are moving smoother with data movement from EHRs to unite us in a smoother manner across the state. We'd like to move this committee to really start thinking about what do we need to put in place from a data technology interoperability perspective, sharing of data for future VBP contracts between our primary care providers and our specific enhanced service providers. So that will evolve over time. And we have an upcoming meeting for that. Oh, I do this because there's a lot of healthcare providers on here. I did want to just say we have a couple of different ways in which healthcare providers can engage. Certainly they can screen and unite us. We provide all the licensing, training, all the support that you need to be able to engage and do this work and unite us. It is our preferred way because we get that screen right away, right? There's no 3-week lag for us to start up. It's immediate and we can do that. You can screen in your EHR. I see EHR spell wrong. Sorry, it's not her. So auto-corrected. I apologize. EHR, and to make sure, and then we will make sure that that data is ingested. And over time, it does smooth out. Like I said, we've had some providers that have started about a month ago. It smooths out over time. Or if you really are not looking to do any type of work in terms of screening, you can just refer to our Healy website. We have a self-screener right on the website. Medicaid members can go self-screen. Those screens go directly into Unite Us, and we can respond to them immediately. So the opportunities that we have. We try to provide a lot of support. We really try, we want to build our network. We want to nourish our network. We want our network to provide us with feedback. We want them to communicate with each other. But we also know we ask a lot. It's a lot to go through the contracting process, to go through the training process. There's requirements we have to satisfy as a network. So we created a provider partnership portal. So as you're going into contract with us, we give you access to this portal. All of our workflows are on there, our tips, our tricks, all of our information. We try to give you a place where you can go and get everything 24/7. So if you're, not able to sleep one night and want to go on and look at those things, they're there for you. So that's one of the things in terms of addition to monthly meetings for Healy, additional committees. We've also provided this portal for our providers to go in and have resources. That's just our next sessions for onboarding onto Unite Us. If you choose to do that, there's a series of again paperwork that needs to happen, and we're in the midst of onboarding right now. If there's interest, please do let me know, and we will get you the paperwork and the needed resources in order to be able to go through the process of onboarding. We've also created a learning management system. So again, there is training that needs to occur. It's required training. It's the training the state has laid out for us. We've created a learning management system. So again, you can go and train yourself 24/7 and be able to access those trainings. So we have all of that, because there's specific trainings. You see enhanced service providers, invoice administrators, social care navigation, enhanced care management, screening only. So you would go on based on your role in utilizing Unite Us and be able to receive that training. We also have office hours twice a week. We have office hours on Tuesdays and Wednesdays. Tuesdays are more general. Maybe if you're new to the network, you really just want to start is Tuesdays. Wednesdays is our more TA, more specific. We also have a ticket system where if you're having an issue, you can send us a ticket and we will respond to it. We have specific Medicaid member engagement. We do have Medicaid members on our governing body to give us feedback, and it's been very valuable to receive that feedback. And we also know we need to do a lot. We have a lot of health systems that are coming on, our FQHCs, our providers. So we know that we're going to start to increase the engagement of people who are engaged, who are connected to organizations and connected to healthcare providers. But we also need to dig into our communities and find those individuals who are not connected, right? That's our responsibility as a social care network, is to find those individuals who are not yet a part of a system, but need these services and can benefit from them. So what we've done is we've hotspotted, we received the data on where Medicaid members are on Long Island, and to be able to, of course, we need to cover Montauk to Elmont, but how do we also kind of dig in where we know our Medicaid members are? Because we have that data, we know where they are by zip code. And how do we dig into those communities and really find those trusted messengers to connect to so that they can also connect to our Medicaid members? We've identified 7 communities, 4 in Suffolk, 3 in Nassau, to kind of start our focus. Again, it's not the end of our focus, it's the start of our focus. We also identified the small primary care practices and the FQHCs that are in those communities. There's a lot of overlap, luckily. And then we also identified the CBOs that are in it. So now we start to look at, okay, in this community, this is where we know there's a high number of Medicaid members that live here. We know that there are primary care practices that are connected to them, and we know there are CBOs that are connected to them. Good start. And then how do we identify those other ambassadors and trusted community members to connect to? And then we have flyers that we do need to get all outreach materials approved from the state. So it's a bit of a process. So, but we do have a way, there's the email there. If you'd like us to customize a flyer for you, we're able to do that. It just needs to come from us because we're required and responsible to get all outreach materials to Medicaid members approved by the state. That's it. That's where we are with that. I'm happy to take any questions or comments.
Wait a minute, am I unmuted? Yes, I'm unmuted. Tremendous amount of information. A gargantuan effort to get all of this done. Lots of CBOs on this call today, at least one FQHC is on the call. Maybe these individuals or these groups are already involved. I'm not quite sure. If you're not, I implore you to contract and help us reach that 600,000 number, which is a big number to crack. I think it's a 10-question form, the
12.
screener.
Mhm.
12,
It's
12,
12, yeah.
12,
Yep.
12, right. First question being, do you give your consent to be screened? And if they
Mhm.
say no, well, then they're not going to be, that counts as the screen because
That's it, yes.
they said no. And so really think about this, all the time and effort. Those of you who remember DSRIP, that the money and effort that went into DSRIP, we did meet the goals, as far as I recall, of reducing the preventable ER admissions. That was one of the major goals. However, in this case, we're even stepping, I feel like, one step further before that, and it's really focused on prevention and getting people those supports that we've known about for years, but we're finally articulating it. Those supports that they need, the nutrition education and nutritional support if they happen to be a diabetic who's not well controlled, a person who might need some more care management because they have complex both mental health issues and also perhaps some chronic diseases that are complicating their case, right? So they need that intensive case management, which is so important. And I saw that there was transportation that links people to get to the services they need. And the previous speaker was, I don't know if you were on, but it was Valerie Lewis. You probably know her from, yeah. She was talking about transportation is really lacking for those with disabilities, those who are in need. And what this is trying to do, this particular waiver, is tighten up and pull all those pieces together to assist this very vulnerable population. So I'm going to stop there. Anyone have any questions for Lori? Certainly you can reach her offline. She's given her email address. I know that at the council, we have been pushing through our communications the link to self-screening, our enrollers who go out into the field and meet with individuals who may or may not be eligible for Medicaid. We bring the flyers, we try to educate them. We're trying to do our part to shrink that number, and I would implore everyone else to think about doing their part. So again, collective impact. If we all do a little bit, we're going to get a lot done. So I don't know if anyone else has any other questions, but good job explaining, because this can be very complicated.
Thanks for the opportunity. I appreciate it.
I still get confused sometimes, but it's it's getting there, and you've done a tremendous amount. It's just a short amount of time.
Thank you. I appreciate that.
Anyone else? And nothing, nobody. Silence. Okay, so you can stay on if you want, Lori. You can go run and go.
Yeah, I do need to hop. I apologize, but I thank you so much for the opportunity.
Sure.
If anybody is interested in joining or participating, more than welcome. We're really pleased to continue to expand our network. Thank you.
Thanks, you, Lori.
Bye-bye.
All right, so we are back to
Okay,
more
the views
collaborative
of
updates.
How many, do we lose a lot of people? I don't know. Oh, okay.
I know it's coming up on the hour, so folks
Yeah,
have
it's
to
just,
run,
yeah, it's
but
getting, yeah, it's a lot. This was a lot. Okay, go ahead, Brooke.
sure. Can you all see my screen firstly?
Yep.
Okay. All right. So the next update we have to share is about our CHNA CHA work group. I think, no, we haven't met quarterly since we selected our regional priorities. So that's one of the major updates for this group. These are our regional priorities that were selected by the group: nutrition security, tobacco/e-cigarette use, and preventive services for chronic disease prevention and control. And then as participants of the work group know, we are working on a CHNA CHA companion report for the work group. We are going to be publishing that as soon as possible. Some of the elements of that include companion material for your executive summary, your community description, health status description, as well as the CHIP/CSP. And we're also going to be providing some peer-reviewed sources to support the priorities, as well as our full membership list for your use and reference. Janine, anything else you'd like to add to that?
No, that's it. The formal meetings have concluded, so that group has done its work. We may reconvene maybe September, October-ish, just for a touch base, but we completed that work.
And we're always available to you via phone, email, anytime you'd like to connect, please feel free to reach out to us. We already talked about the case study.
Yeah.
So just some ongoing engagement, the community health assessment survey. We do have versions that are new as of January 2025. And we do have a lot of folks who continue to distribute the paper version. So firstly, I just want to thank everyone for doing that. We recently have received some paper versions that are still the old survey, which our analyst is able to include in the analysis, but please just double check that you are using the most recent version if you are distributing those paper surveys. As you might remember, the new ones align a little more closely with the new prevention agenda. So we just want to make sure that we're collecting as many new surveys as possible. And we do have that toolkit available that has, QR codes, paper copies, and copy for your newsletters and social media and things like that. We are going to be and continue to promote the products of each core cluster that really all culminated at the beginning of this year. And of course, these 3 deliverables you see here will also be part of the CHNA CHA companion report. So those will be interventions that everyone can take collective ownership in their CHAs and CHNAs. Oh yeah, collaborative communications, as you all know, goes out every other Monday. Please continue to send us all of your free events, resources, job listings, anything that you might want distributed to the collaborative membership. We're happy to include it. We also have our events calendar available for your use. Please feel free to publish any and all events that you'd like to add there. And Walk with a Doc and Walk Safe with a Doc, we continue to hold those events. And as always, we, secure a physician. If you're a hospital, we'd love to partner with you. I know Josephine has been a really active participant in our Walk with a Doc program. So we'd love to partner with you on an event like that if you are interested. And speaking of which, we have some coming up. We are doing a spin on Walk with a Doc this year that they're going to be healthy hikes. So the first one is actually happening tomorrow at 9 a.m. at Connecticut River State Park. If you're interested in joining us, we'd love to see you there. But this is a continuation of our partnership with the AARP Long Island. They are sponsoring these hikes. And so these are the other dates that we have through September.
And we're bringing the Long Island Greenbelt Trail Conference into this as one of the partners as well. So we're hoping that their extensive outreach list will bring a good number of people to do these healthy hikes. We'll see how it goes.
Yes, and they are going to be led by, well, the first one I know is going to be led by David Ricefield. He is the director and president there at the Greenbelt. So these are all guided hikes. So love to see you there, whether you're a beginner or an experienced hiker.
Yeah.
And just want to remind you that our monthly Walk with the Docs are continuing. We are skipping July just because the first Thursday of July would have been July 3rd. Folks are probably going to be barbecuing, etc. So the next date that we'll be walking at Blydenburg Park is Thursday, August 7th. Dr. Keisha Guerrier from Northwell Health has generously agreed to lead this entire series of walks, and she gave a really fabulous talk last time with some great tips that we can all kind of apply in our everyday lives to be a little bit healthier. So we would love to see you there as well. And if you can't join us in person, we do have a Zoom version, so where you can hear Dr. Guerrier's talk and, you know, maybe go on a walk in your own neighborhood with us virtually. So love to see you there as well.
Yeah, and certainly feel free to promote these walking events among your own constituents and patients or whomever it is that you regularly service. She's fantastic. She has great tips. I'm not going to divulge the tip that she offered last time, but what you'll have to do is attend the next walk to learn one of her great tips. She's fantastic.
She really is. And just a reminder about our other quarterly meetings. So the next one will be in September, and that is on the 25th. And of course, the links for all of these are on our website, so you can register in advance.
Okay.
And that came a little bit later. So any discussion or any questions before we adjourn here?
I know we've been on for quite a while, and really had to digest lots and lots of information, but I think it was really good information that we were provided with. So, unless anyone else has anything to add, I think we can conclude the meeting. Hearing nothing, I say, yes, have a great weekend. And maybe we'll see you at the Healthy Hike tomorrow morning.
Yes, thank you everyone for your time today.
Thank you.
Take care, you guys. Thank you.
Thank you.
Thank you.
Thank you.
Bye-bye.